Hi, everyone. I'm Vincenzo Berghella, and once again, welcome to another edition of Live at AJOG MFM. It's a pleasure for me today to have Corina joining me to talk about induction. Corina, can you introduce yourself, please?
Sure. My name is Karina Schoen. I'm assistant professor of OBGYN at UMass Chan Medical School at Bay State Medical Center.
Great. So, as you saw on social media, we're going to talk about induction of labor and base this on the evidence. And there is a humongous amount of evidence. I think actually induction may be the one topic. I always say, with the most randomized trials, there's so much evidence and it's hard to put it together. We've done already a lot of prior AJOG-MFM live events, and you can still see them on Facebook, Twitter, and YouTube. We've talked about AJOG-MFM, manual rotation, how important our CTs are in our field of obstetrics, COVID vaccine, ultrasound in labor, twins, and preparations in labor last. And so we're continuing to talk about labor issues today. You can watch all these live, and obviously you're watching us live today on Twitter, YouTube, and Facebook. Just to remind you that you can ask questions live over the next hour or so. The easiest way to ask us questions is to go to YouTube and ask questions that way, either on AJOG-MFM on my YouTube accounts. So again, this is the second in the series of 10 evidence-based labor and delivery management things that, none is more important than the others, but certainly induction, as I say, is the one with the most randomized trials. And AJOG-MFM has published, as you'll see, many of this. Corina is certainly a major expert in this field. I was looking back, Corina, and you wrote the induction chapter, or co-wrote the induction chapter in both the third and now fourth edition, which just came out for obstetrics evidence-based guidelines. So a lot of that is here, and obviously a lot of the evidence, meta-analysis of randomized trials and randomized trials, it's in this paper at AJOG-MFM. With that, you want to go through over like kind of what we're going to cover, Karina?
Yeah, so first we'll touch a little bit on predicting vaginal delivery for those women who do need to have an induction of labor or want one at 39 weeks. We'll do a little bit of the timing of inductions for medical indications and otherwise, and we'll probably touch on that more towards the end of the show just to see if we have time. We'll go over some selected cervical ripening methods, a little bit of oxytocin management once you're in the active phase, and talk about induction in special circumstances for things like prom and for women who are trying to achieve a TOLAC. We'll cover outpatient cervical ripening as well, and a little bit on the definition of failed induction.
Sounds great. So let's start. And again, I think that we put a lot of information together, and I hope that other societies, ACOG, SMFM, and other societies around the world, continues to focus on labor. It's so important, and so common. Induction is certainly not going away. So first of all, how can we predict the vaginal delivery? For example, when we are faced with an induction.
Yeah. So if I don't know how much you use your ultrasound while you're on the labor and delivery unit. You probably use it a lot, actually. But if you are doing a transvaginal cervical length for women, we know that if you do have a short cervix, less than 20 millimeters, that does have an 80-90% chance that you're going to have a vaginal delivery, which is great. I don't know if all ultrasound units are really, all labor and delivery units are using a transvaginal ultrasound beforehand, but certainly can help in aiding it. And I think that really supports what we've already known for many decades. And, Bishop has developed a score that when it's greater than 9 is about a 96% chance of vaginal delivery. So it's very helpful, I think, for counseling your patients. But as we all know and teach our residents, less than 6 doesn't really have a great sensitivity predicting a cesarean section. It really just means that those women need to have cervical ripening done. So I wouldn't necessarily steer those women away from having a trial of labor, certainly.
Thanks for emphasizing cervical length. It's really something I love and I dedicated a lot of my career about. We talked last time about the fact that cervical length, if done at 37, 38 weeks, can actually predict when you go into spontaneous labor. But in this case, these are different references, and they're actually on induction. So a pre-induction, you can kind of um, predict how what the chance of vaginal delivery, which again for women it's up there as well.
Yeah, and there's a couple of calculators that are starting to come out as well. I know UPenn has recently published a couple papers on this, and they've tried to internally validate and externally validate a calculator, and it's actually available on their website if you're interested. I think these are great for adjuncts to really counseling your patient, but certainly you don't want to steer one patient, away from an induction just because the calculation might be low. It may be something that you can use throughout labor, especially if you notice it's not going well as far as shared decision making, but not something that I would use at the front to say this person should not have an induction.
Excellent point. Excellent point. So let's talk about some of the methods, and there are so many. We could talk about all day, but certainly the Foley seems to be kind of the mainstay, at least in 2022. Do you want to go over some of the evidence?
Yeah. So I love using a Foley catheter, mostly because its ability to be combined with other things, which we'll cover. But it has a lot of benefits. One, it virtually has no risk of tachysystole or hyperstimulation. It does have a fairly low risk of infection, and it's been shown in several meta-analysis with several tens of thousands of women. So the safety profile is excellent. And it's also available in low resource settings. It's very cost effective. You can get them for a couple dollars doing one of the smaller Foley catheters, the 30 cc balloons, versus maybe $12 to $15 for some of the larger balloons, the 60 to 80 cc balloons that you may want to use. Some of the cons are places where you may not want to consider using a Foley catheter. So it's not the most ideal method if you do have ruptured membranes, and there is a potential infection risk there. I know when I was in training, we were using it, and we didn't think that the infection risk was high. And then there have been trials that came out afterwards. I know Dr. McKean has published recently showing that it hasn't, as an adjunctive agent with prom inductions, there was a statistically significant increase in the risk of chorioamnionitis. So it's something that we've moved away against. And then by itself, it's may have longer periods of ripening compared to some of the other methods, such as prostaglandins, especially misoprostol. So you really have to be actively managing this.
Yeah, and most induction we'll talk about are in patients without rupture membrane. I think if anybody wants to look at the evidence, they should look at that reference you put in for McKean at the Great Journal last year, just a meta-analysis, like you said, of over 600 patients, and shows that trend, for chorioamnionitis. So I think oxytocin, as we'll show later on, much better agent for rupture, but otherwise, Foley, it's a wonderful agent for somebody who's not rupture. So, but how do we use this Foley? There's so many little things you can do, and so much controversy on.
Yeah, so it is well studied, especially in like how to place it, and a lot of the different methods that go around using the Foley catheter. So you can place it with or without a stylet. I've used both. I think certain patient characteristics will lend itself to one way or another, but there is a study looking at this. They showed really no difference in the successfulness of placement, rather that it was really more in tune with how dilated the cervix is. And anyone who's put in a Foley catheter will also understand that, of course, if they're more dilated, this is easier to do. And it's also correlated to PGY year. So, a PGY4 was much more successful at placing a Foley than a PGY1. So there is a trial showing that. So basically you can choose either or. There's a trial on speculum or blind insertion. This was particularly looking at infection risk, and they found no difference in the risk of infection or successful placement with either speculum or blind insertion. Interestingly, if you used a speculum to insert it, you are more likely to have to get it inserted again for a second round of mechanical ripening. And I think that might have to do with the lack of kind of tactile information you're getting from confirming that the bulb is actually above the internal os. But again, you can use it, especially if you have a difficult insertion and you're not going to get it in any other way. And then we recently looked at putting the traction on a Foley catheter, whether that's helpful or not. And so that's going to be published in AJOG MFM as well. And I think if you click on the next slide, we'll show one of the forest plots on this. And so one would think that if you have traction on the Foley catheter, it's coming out sooner, and you're starting your induction, that you would actually deliver sooner, but that is apparently not the case. So this just shows that the time to delivery was really no different, whether you had the Foley catheter on tension with either tape or a weighted bag, for instance, than if you did nothing. So this actually is kind of nice because you can be, feel a little bit better about putting this in our patients for outpatient Foley and sending them home and not telling them just not to worry about when it falls out, it falls out.
It's so important to emphasize, as I have in prior shows, that there's so much evidence on this. I hate to sometimes hear strong emotions. Oh, absolutely put this on tractions, or absolutely you can do it blindly. It's better than speculum, or vice versa. And there's good evidence, and I think the first step in being a good clinician is to know the evidence, and then based on that you can decide. And traction, for example, we're not using that much anymore based on your data that, again, AJOG MFM is publicizing, so to speak. Same thing for some of the other stuff. I think we let our residents decide if it's blind or speculum.
Mm-hmm.
Some people are better one way or the other, I feel sometimes, but there's certainly an experience level. I'm glad you talked about the resident level making a difference.
Yeah. So moving on, there's other considerations. I talked a little bit about the variation in sizes that are available for Foley catheters. So size does matter a little bit. When you're able to use a larger balloon, there is a modest reduction in time to delivery. So it's about 2 hours in the meta-analysis that we published a couple years ago. And I think the next slide will actually have some data on that as well. And so this is just a meta-analysis of a couple of the randomized studies comparing the smaller, which was anything less than 50 mLs, to the larger bulbs, which is 60 mLs and up. And so we did find that the time to induction to delivery was significantly shorter when you were using the larger balloons. So this doesn't necessarily have to be a Cook catheter. I think a lot of people and a lot of institutions have moved towards the double balloon catheter, but this is actually all single balloons in this meta-analysis. And then touch on just double balloon catheters briefly is, so the meta-analysis for those, and that reference isn't included here, but about 5 trials show that they didn't outperform Foley catheter single balloons, and there was slightly less patient satisfaction with the double balloon catheters, which was an interesting finding. I think there's a little bit more discomfort with them. And of course, they are a little bit more expensive than the single balloon ones.
I guess my role here is to push you, and to kind of say what we do, what you do. I mean, based on this evidence, and again, 1,432 patients, and the one we have on the slide, it's not, over 1,000 patients. It's quite a lot of randomized studies, and sweat and tears of all of those who have done those randomized trial. 2 hours, I think it's an important, it's not, 10 minutes. And we know that the longer labor is, the longer you have a chance to eventually, get in labor, to get choreo, to get postpartum hemorrhage and other complications. So because of that, I think, considering a 60, or some studies even use 80 instead of a 30, which is commonly used, it's better. And like you say, we don't really use double balloons, more expensive and no need. One larger, like 60 cc's balloon seems to work really, really well. And you also, I don't know if I'm sure you remember, you published in AJOG MFM a paper, I think, titled "Blown Out of Proportion." Do you want to tell us about that one? We didn't put it in this. Just remember.
So we published that after we had a couple of actually balloon ruptures in my original trial I did on induction, comparing Foley and Foley oxytocin for labor induction. So we were using the larger catheter sizes because that did have evidence for benefit. We were overfilling some 30 cc balloons, because I think that's still kind of common practice in a lot of places. And we were filling 30 cc's to balloons with 60 mLs of fluid, and we had 3 separate ruptures in that trial. I know it's happened in some other trials as well. And so we published that with Dr. Pecker and just about our experience at Jefferson and Christiana, where the trial was done, and at Yale, where he experienced his ruptures, and that you really should be following the manufacturer's advice here, because you can actually get retained fragments that require surgery or hysteroscopic removal afterwards. And there are manufactured items on the shelves where you can buy, and they are not really expensive. So I really do promote using the larger 60-80 balloons, and they go up to 80 cc's. So that's definitely something I recommend. You don't want to tell a patient she's in labor that you're missing a part of her Foley balloon. That's just not a conversation you want to have.
And it happens. And thanks for reporting it. And so really important, 60 cc's, like you said, and use the right size, the 60 cc's to begin with. Don't blow it to a 30 cc away.
Yeah.
The next point you want to make?
Yeah, so I touched on this a little bit before, that if you're going to use a Foley catheter, the ripening times are a little bit longer compared to, say, misoprostol or dinoprostone. And so active management is really essential. And so there's a couple of trials. These are done with the Cook catheter, showing really more of an early progression towards oxytocin augmentation after your cervical ripening period is over. Can significantly reduce your time to delivery. And so if you go to the next slide, to these 2 references here. So Dr. Gu et al. Did a 4-arm study comparing 30 cc balloons removed at either 12 hours or 24 hours versus 80 ml balloons removed at 12 and 24. And they found that removing it at 12 hours was really much more effective. So you see those lines in the blue and the yellow showing a significant reduction in time to delivery. And then a more recent trial by Dr. Blecker and colleagues out in Boston also showed a similar reduction, and they were looking at removing the Foley catheter at 6 hours versus at 12 hours, and then immediately going on to an oxytocin augmentation. And I believe in amniotomy in that trial was really just provider preference at that point. But they did show, just by taking out the Foley catheter, not waiting for that spontaneous expulsion, that they could significantly cut down on the time to delivery. And it's such a minimal thing to do to make sure you're doing active management of your patient. And so that when you're using a Foley catheter, that's definitely what I would recommend, is not letting it sit in there.
So do you do 12 hours or 6 hours now?
I do 12 hours personally. And there's only this one trial that I'm aware of that really took it out at 6 hours. And the other thing is, I'm usually doing combination methods unless there's some contraindication for that. And so there is always that second ripening agent that's also working. And so usually I'll cut it at 12 hours.
Yeah, and so do we. It's kind of the eternal debate. Do you want to be the first when the trial comes out? Do you want to be the last and wait for 4 or 5 large trials? I think in this case it makes sense. It's 100 or less. So on the smaller kind of size trials, well done. I'm hoping like part of this shows are to kind of give ideas out, and this is something that we may have enough evidence for 6 hours soon. So get going, you young residents and fellows and young faculty to do this. I think it's a good randomized study to do. We used to do 24 hours and leave it on forever. 12 is much better, and who knows, maybe 6 will be.
Yeah, I mean, certainly if you're still doing 24, I would definitely cut down that time period and start moving to your oxytocin much quicker.
Speaking of another agent, meso.
Yeah, so meso is great. It is very cheap. It's very cost effective. You don't have to worry about refrigeration, which is wonderful. There's a lot of different dosing regimens that are out there and methods of how to give it, slightly different pharmacology behind that as well. In general, we do recommend low dose misoprostol. High dose is not recommended for term induction. So that's anything over 50 micrograms. The risk of tachysystole hyperstimulation and meconium is just really too high, with a very, very minimal benefits for things like C-section. And so we're definitely staying under 50 micrograms. Low dose oral or titrated dosing is great. If you're doing an oral dosing, you can do 25 micrograms every 2 to 4 hours. If you're doing vaginal dosing, it should really be every 4 to 6 hours. There's some limited evidence around buccal dosing, but there is a recent trial that just came out in AJOG in 2021 by Dr. Gomez and colleagues at Christiana. And they actually were comparing the buccal misoprostol to vaginal misoprostol, and they actually showed a pretty significant reduction in time for the vaginal dosing, which was interesting. And it just goes to show you that with misoprostol, it's been around for decades for induction, again, off-label, but what we've been using for decades in obstetrics, we still have things to learn. There's some limited evidence around buccal, but I know, like, when I did my training at Jefferson, that was like the hot topic. We were doing buccal for everybody, and now, maybe we shouldn't. So I think there's enough crossover in some of the confidence intervals, especially when you're looking at the meta-analyses, that you can kind of tailor this also to the patient. You are going to have patients who want to try and avoid vaginal exams, and that's okay too.
So again, what do you do in Massachusetts now?
So we do either oral or vaginal.
And what's a dose?
And we're doing the oral, we're actually doing 25 every 2 hours for 6 doses.
And in Europe, they do that a lot. Go ahead.
Yeah, so I think it depends on the practitioners too. I have the residents, and I teach them. They're like right on board. They want to get on board with the new trials, and they're doing the quick dosing. And then sometimes we have people who have been practicing for a really long time and know what worked for them, and they're doing 25 Q4 hours vaginally, and that's fine. So and I think you have a discussion with your patient too.
Yeah, and like you have it at the bottom of the slides there, Cochrane of over 100,000 people is just humongous, and you can get lost, in the data. We do for whatever, it's not that everybody needs to do what we do, but it's I think what you do is perfect, and right. We do 25 Q3, often maybe 25 Q3, and then the second dose is 50. I wouldn't recommend start with 50 ever. You need to kind of give the baby a trial. We're actually doing, Lynn LFS, one of our fellows, is doing a randomized trial on fetal growth restriction. You talked about on the slide there, prior C-section or myomectomy shouldn't use meso, obviously, if you're contracting too much. But for example, with growth restriction or a baby that may not tolerate labor as well as another baby, we're trying to find out if we have about 4 more patients to randomize, so 150.
That's great.
And so hopefully she'll send that to SMFM. But again, you have this extremely effective. This is something that can be used anywhere in the world.
Mm-hmm.
Low cost, low, easy to maintain, no refrigeration, et cetera, et cetera.
Yeah. So this I think is particularly helpful, especially if there's any of international colleagues out there. This is just the misoprostol regimen, and it has a couple different obstetrical indications for use. Whether it's early pregnancy termination or miscarriage management, mid-trimester IUFD, or term management. And you can find this at www.figo.org. So I find this very useful, especially if you're not practicing in the U.S. and need some guidance.
Yeah, they have the 25 over 26 weeks in the blue column. I'm just noticing they have the 25 microgram PO every 2 hours, which again, my experience is that's used around the world very commonly. And when I was a resident, this is what we used all the time, and we never use it anymore.
Is that misoprostol or dinoprostone?
No, dinoprostone. I changed slides. No, we use meso all the time. As the message you'll give is Foley and meso or PIT. PGE2 we don't use as much.
Yeah, I remember being trained by some physicians that would tell me, they would come in for their term labor check. We'd sweep their membranes with some Prepidil and send them home. We don't recommend that anymore. But so dinoprostone is, it's still used, a lot. The dosing's either a 0.5 grams gel, that's the Prepidil brand name, which is the little syringe picture I have there, or the slower release pestarate, it's 10 milligrams. And that releases about 0.3 milligrams an hour, and it's usually for about 12 to 24 hours. So as far as efficacy for dinoprostone or PGE1, it's got a slightly lower vaginal delivery rate if you compare it to the misoprostol regimens. It's also slightly more expensive, so take that for what you will if you're making your choices as a labor delivery director about what you want to have on your L&D unit. And then the labors are also slightly longer than misoprostol alone. So I tend not to use dinoprostone anymore. I know you mentioned Lean's RCT that's hopefully going to be completed soon. I know there's a lot of people who want to use that Cervidil because they have the ability to kind of take it out, where you can't do that with misoprostol or the Prepidil. Interesting is that in the meta-analysis, the slow release pestarate, which is what Cervidil is and what we have used in the United States, actually has higher rates of hyperstimulation, so tachysystole with fetal heart rate changes, compared to the low-dose misoprostol regimens. So if you have a potentially compromised baby with suspected fetal growth restriction, my thought is you don't want to use the drug that has a potentially higher stimulation rate. So I understand the logic behind you want to take it out, but my thought would be use something where you don't have the risk in the first place.
Yeah, completely agree.
So if you go back one more, I was just going to say that, so making sure you're not using this with prior uterine scars, that is a contraindication. And that if you do have contractions, that you should also not be using this and moving towards something else.
Yeah. And then laminaria.
Yeah. So I think new interest in laminaria because there's a new FDA cleared formula on the market now. This is something that you do insert under direct visualization. So I have the picture on the side, speculum with a ring forceps inserted into the cervical canal. It's stable at room temperature, which is nice. The new FDA cleared product is a synthetic material, so there's not really that infection risk that I think a lot of people were worried about with term pregnancies. In the meta-analysis showed that there's similar efficacy in achieving a vaginal delivery to dinoprostone, amniotomy, or Foley. Not a lot of trials on laminaria, so I'll just put that for the meta-analysis at least. You can't use it if the membranes are ruptured, but the costs are a little bit higher. So there was a recent trial, non-inferiority out of Texas by Dr. Saad, and it did show similar vaginal delivery rates, similar infection rates. So it is an option, but obviously you want to weigh cost benefits, and potentially in the future costs may come down too. But some interesting side effects and adverse effects you need to be worried about are things like creating false tracts and cervical lacerations. So just to kind of be aware of those things as well.
Yeah, we I used to use some of this more again a long time ago, decades ago, in residence. We don't use it that much anymore. There are 2 more trials I think coming out in Europe. That's why they're doing a guideline and invited me to comment on it, to kind of think about this as a replacement to the Foley. I just think that for now there's so much more, as a mechanical dilator, there's so much more evidence for effectiveness and safety for the Foley. But like you say, this is cheap as well and easily available, and so I'm looking forward to those couple of trials coming out soon and to more evidence.
Yeah, absolutely. So big thing is don't do it alone. So we now have a lot of evidence saying that if you can combine your induction agents and your cervical ripening agents, you're really going to have a much shorter time from induction to delivery. The meta-analysis don't really show that there's any effect on C-section rates, so that's too bad. But we really should consider either adding prostaglandins or oxytocin to your Foley catheter. Now you can use either. So we recently published in AJOG a network meta-analysis comparing Foley catheter and prostaglandins to Foley catheter and oxytocin. And the reason why we had to do a network meta-analysis is that really the only head-to-head trial comparing Foley and oxytocin and Foley misoprostol is the one by Dr. Levine at a UPenn a couple of years ago. And so at least based on the network meta-analysis, there really was no benefit over one or the other. So you can choose, whichever is best for the patient. In general, I choose misoprostol, and some of my residents are surprised. They say, Dr. Schoen, your trial is in Foley and oxytocin. And I say, oxytocin is expensive to run. You have to have a nurse at bedside all the time. So do what's best. And like we said before, misoprostol is really cheap, and you don't need to have a nurse constantly changing your titration, which is really nice. And there's a couple other meta-analysis as well, looking specifically at Foley versus Foley and oxytocin, and again, consistently showing a reduced time to delivery, but no change in the C-section rate. And at least at this point, with a couple of thousand participants, no safety concerns as well.
I think you changed the world. You and Lisa Levine, like you said, and others really changed the world. We always talked about one versus the other. And now a huge message, I think maybe one of the main messages today is, you should use two methods. And the methods you and I use more often, if there's no contraindications, are Foley and meso at the doses and the sizes, etc. we recommended. And if meso is contraindicated, Foley and PIT, which you studied as well. I remember and you'll talk about it later on. Inductions last forever. Some people are afraid for it. When you talk about a patient about an induction, I don't want to be in labor for 3 days. Some of your trials had mean time, from nothing, from close along to delivery of 14 hours, 16 hours, 19 hours. Again, there are some that are going to be over 24 hours, but there's no question that if you use the two agents, Foley and meso as a first choice, if possible, you gain time, and you avoid potential complications of long labors.
Yeah, and the patient satisfaction is going to go up too. I mean, nobody wants to be ripened for 24 hours before they even get their Pitocin. So I think as far as patient satisfaction, active management of your Foley catheter, doing combined agents is really beneficial for everybody.
Yeah. So important. Such an important message. What about other options?
So this is just my fun side of all the things that we've been trying in the past that haven't really come to fruition. And some might in the future, actually. So this is not that a never do. This is more just of we don't have enough evidence yet. So mifepristone, might be something that's very beneficial. I think there's trials in VBAC, and I would love to have more of that information on mifepristone specifically. But these other agents or methods really have been shown to increase induction. Sexual intercourse doesn't promote induction, and I think Dr. Saccone had recently published on that. Breast stimulation hasn't so far, though there is a trial coming out, I think soon in AJOG MFM, very small pilot study looking at breast stimulation. So if people are interested, by all means, check that out in the upcoming articles. But things like enemas and baths don't really have any evidence behind them. Absolutely say no to castor oil. I think some people still try it on their own at home, but just universal nausea with mothers, and that without any evidence, but that's going to send you into labor. So these are kind of just interesting things to see historically what we've tried, and there's a couple new things on the horizon, hopefully.
Certainly something for people to think about. I'm always amazed, at the actual evidence. Found 3 at least, or maybe there are more randomized studies on sexual intercourse. Some people still say that, be active with your partner, the next couple of weeks, the last couple of weeks. And that has not shown benefit, at least in terms of, going into labor. Sexual activity is obviously very beneficial in pregnancy. That's been overwhelmed. And there's actually a book we're about to publish on sexual activity in pregnancy. While nipple stimulation, some people call it nipple, some people call it breast, there's actually like a meta-analysis of 6 trials showing that may decrease the time, from when you do it and when you deliver, kind of like striping on membranes. And Stark and so on, they actually published already in AJOG MFM their pilot trial, are going to do a larger trial. Certainly seems to be safe, but I think you and I don't use it yet, as we don't use the other things on the slide, just because
I have used it. Like I said, some patients don't want other methods, and like I emphasize the fact, like, this has to be shared decision making. You give them what the evidence is, and you come up with a plan together. And we have some patients who are like, no, I don't want anything, and I don't want anything. I don't want a vaginal exam until later. And we've tried this, and I think what Stark's pilot study showed that you actually have a little bit less need for oxytocin, and they were able to get into
Yeah.
labor, though it took like a little bit longer. And I think the satisfaction studies were they would do it again, and the nurses liked it because they were less, they weren't in the room as much titrating their oxytocin. So, there are some things that we say no to or should discourage, things like castor oil, but there's, things like nipple or breast stimulation, you might have a population that really wants that. So,
Yeah, yeah. Before we went on, I found a randomized study on castor oil from Egypt. I read it in more detail, and there's remember progesterone, 17 hydroxyprogesterone caprate, the used in castor oil. Maybe that's why the placebo, had more preterm birth. I think on some of this, we need more information,
mhm.
and so lots of ideas for the future. What about sweeping amendments? We've mentioned this here and there.
Yeah, so that first bullet is just from the last live stream saying if you can prevent an induction, that's actually best, right? So it's doing it before labor induction at 37 to 38 weeks. When you add it to labor induction, it actually can increase the chance of vaginal delivery. So that was found in meta-analysis, and so just doing it right before your cervical ripening agent. Though when they looked at the sub-analysis, it may not be as effective for multiparous women. So take that as you will, but it's a very easy intervention. So it is actually something that I routinely practice when I'm pulling the Foley catheter in. It's usually stripping the membranes first.
I think another very important tip, low cost, and easy to do. What
Yeah.
about rupturing membranes?
So
Yeah.
I love this. Again, very low cost, but I think there's been a lot of reticence around this, especially for induction, because you're setting your patient up for a longer time in labor because they're not in spontaneous labor. And, how does that amniotomy, especially early, play into the roles of things like infection, especially if you need multiple exams to see how their labor course is going. And so I think we now finally have a really good body of evidence to say that if you are having a labor induction, not necessarily spontaneous labor, but if you're having a labor induction, you really should be aiming for a routine early amniotomy, excuse me. So the meta-analysis by DeVivo et al. And also by Kim showed that there's a reduction in time to delivery, about 5 hours. There is no increase in cesarean rates. And specifically, the meta-analysis by Kim and colleagues showed that there was no increase in infectious morbidity. And I think that's a pretty big concern for practitioners is what this does. And now, importantly, I want to point out that this is in contrast to a lot of the retrospective studies. So when you are not controlling for why an amniotomy is performed, then you can get some of this, I don't want to say false data, but like you can get in a picture where an early amniotomy is actually tied to C-section, tied to infection. The problem is because they're not being randomized, those patients who are getting an early amniotomy or amniotomy, quote, less than 4 centimeters, maybe not necessarily the timing, why are they in labor for so long? So were they always intended to have a C-section because their labor progress is protracted? And so I think you have to be really careful when you're looking at this data to make sure you're understanding the reasoning behind the amniotomy and really focusing on the prospective data.
Yeah. Piggybacking on that, the DeVivo meta-analysis when we did it was really hard to do because there are so many randomized studies on amniotomy or induction. You can even do it as a first agent and stuff, and it doesn't work that well. In that meta-analysis, we looked specifically at people like you have it here after ripening. They had got Foley and something else, meso, ripening. So after they are ripened, 3, 4, 5 centimeters dilated, obviously they have to have a station. We need to mention station here that you're not going to drop a cord with amniotomy. But you have we're talking about 12 hours. So Foley and meso, let's say 12 hours, Foley comes out, she's 4 centimeters, 80%, -2. What do you do? Do you rupture or not rupture? That's really the clinical scenario. And these 5 randomized trials and other meta-analysis of trials, etc., clearly say you can save 5 hours average, and you have no risks. no arm. So I think it's now we finally have the evidence, like you say, to do this.
Yeah, if you go to the next slide, we have a couple of the data points from, so the first ones are from DeVivo, and I think the top one is the C-section risk. You can see that there's no increased risk there, and the bottom force plot will show time to delivery, showing, again, much more for favor of the amniotomy. And I think I have another picture here from, so this is actually from the RCT from Gomez-Slagle that was just published. And they show that when you had an early amniotomy directly after cervical ripening, that you significantly cut down on their time to delivery for vaginal delivery. And then those who ended up with a C-section for whatever reason, that time to delivery wasn't really altered. And the last one, again, is from the Kim et al. Meta-analysis. And this was the 7 RCTs as opposed to DeVivo, which only had the 5. And they included women who didn't necessarily have ripening ahead of time. But again, similar findings, and no change in infectious morbidity, which was a really good finding.
So what about this? What about considering stopping the oxytocin if you're using it?
So I will admit this is not my usual practice, but there are trials, and there is a meta-analysis that show that this is a potential, and I do practice this in certain cases. So if you randomize women to having their oxytocin turned off once they're in the active stage of labor, so 5 or 6 centimeters, versus continuing, the meta-analysis showed that there was about a 35% lower chance of cesarean section, which is a big deal, and about a 50% lower risk of tachysystole. Some of the potential disadvantages, and again, these are minimal, but there's 30 minutes longer in the active phase, and then about a third of patients needed their oxytocin restarted anyway. The evidence is there, but for some reason, it's not something I routinely practice. Unless I certainly, if I see some fetal heart rate changes, and then you're reducing your oxytocin anyway. But I'm kind of have that in the back of my mind that, even though I'm doing this for intrauterine resuscitation, I'm not significantly changing her risk of having a vaginal delivery, because once she's in active labor, then she's probably going to do well. It's something you might want to avoid, especially if you want to have an expeditious delivery. Preeclamptics, especially severe preeclamptics, help, but something you can consider for patients who want minimal intervention. What about you? Are you doing this on the floor?
We're exactly like you. We're not doing it routinely, but I think it's important to be aware of the data. Obstetrics means to stand by. Ob status. Stay around. But we're getting a little bit more impatient now that we know that a longer labor can have issues. We discussed infection and bleeding, and I think especially if you can save some C-sections, I think inductions can get you to the active phase. That's really the hard part.
Mm-hmm.
Getting from 0 to 6. Once you're 6+ and you're contracting, your body probably by then recognizes you're in labor, makes its own oxytocin. And baby seems to tolerate it better if you have less oxytocin. So I'm all for oxytocin. I think you're too, but sometimes we may give too much, especially later on. And this, I guess, it's your algorithm, or
yes. So this is just a proposal of how to manage in general. So obviously, before they're even in your labor and delivery unit, considering labor induction, please do membrane stripping. You're going to prevent a significant amount of patients from even arriving on your doorstep for their induction. They're going to come in spontaneous labor, which is great. When you start the ripening, Foley catheter 60 to 80 mLs for 12 hours. If you don't have any contraindications to misoprostol, that is what we recommend using along with the Foley catheter. So either orally or vaginally. And then if they do have a contraindication to misoprostol, you can start oxytocin at the same time with regular titration, not necessarily just low dose oxytocin, but really increasing it as well. After removal at 12 hours, really immediate institution of oxytocin. Continuing if you're already using oxytocin as your combined agent, of course, waiting the typical period if you're using prostaglandins, about 4 hours. Starting your GBS prophylaxis is needed. And then once safe, so once feasible, you have enough fetal descent, then going forward with amniotomy, and then routine management in the active phase.
Beautiful algorithm. I love this in papers. Um, Let me actually talk, if you don't mind, about this issue. I feel very strongly
Yeah.
about it, and we did this meta-analysis recently published in AJOG MFM. I trained uh, at a time in which somebody would call you 2 in the morning. I perhaps remember I'm 39 weeks, and you would say, "Oh, stay home. There's no rush. Maybe if tomorrow afternoon, 24 hours later, labor come in." And I don't think that that's evidence based at all. We found many trials that Belusi meta-analysis there as almost 3,800 patients randomized, and basically the randomized to induction at 4 hours, 6 hours, 8 hours, within 12 hours, or waiting the 24 hour. And clearly, maternal morbidity in terms of chorioamnionitis, hemorrhage, etc., is decreased. And I put up that on the upper right side, that graph. You haven't seen it. It's from a 1970 AJOG article, so 52 years ago. And let me see if I can show it a little bit better, actually. Uh, so it's actually perinatal mortality on the Y axis, and on the X axis is the
Incredible.
latent period. And as you can see, less than 12 hours time from rupture to delivery, it's very low, and it clearly increases with time. So um, we don't have perinatal mortality, thank God. We worry about 50 plus years later, but certainly we still worry about choreo and stuff. So I think if somebody calls you 2 in the morning, I would tell her actually come in, and hopefully she comes in within 6 hours. We did a sub analysis at 6 hours, and there are enough trials to show at 6 hours significance. And then you start, the shown recommended Foley and meso. I'm sorry, this is rupture membrane. Actually, you don't start Foley, not strong recommended. You start oxytocin. I think that, and if you look at these trials, and some are more recent, but a lot of them are from the 90s, from a while back, and there's overwhelming evidence that oxytocin is the best, even if you're unripened, is the best agent for somebody who's ruptured. And we're talking about mostly term patients, or patient 34 plus or 37 plus that rupture, and you want to deliver for whatever reason.
Yeah, absolutely. And then the more recent trials, looking at, so I think Dr. Amarosa in 2017, Dr. McKee in 2018, were looking again to this combination method of cervical ripening for PROM because it's shown benefit in other populations. And so using oxytocin for both arms, but one arm had the addition of a Foley catheter. And that's where we see some of that infection data coming from, with that addition of the Foley catheter. And but it all came with no benefit either. It was all harm, because you have that infection risk, but then they didn't deliver any faster either, and you didn't have a reduction in your cesarean section rate. So, there's one other trial recently on looking at misoprostol versus oxytocin. Again, there's really no benefit. So just start oxytocin.
What about induction in special circumstances like a TOLAC?
Okay, so obviously spontaneous labor is the most ideal, but we can't guarantee that for all of our patients, unfortunately. So the attention is mostly around how do we safely do cervical ripening for these patients. And so obviously Foley catheter is the most ideal, because you're really getting that, organic prostaglandin release that the patient can do on their own, and there's no risk of the tachysystole, followed by an oxytocin induction. So you can use an oxytocin induction, and in meta-analysis of the observational trials, it does slightly increase the risk of uterine rupture, but it is still exceptionally low. So if you're comparing the risk of rupture for spontaneous laborers with and without oxytocin, it's about 0.5% to about, I think, 2.3% risk of rupture, which means 98% of patients are not going to have a uterine rupture, which is really great. And then as far as successfulness for induction, a majority of patients will still deliver vaginally, even if they need an induction after their cesarean section, which is great because then, we weren't able to prevent the first cesarean section, but then we can prevent the second and the third. And of course, this is where we see a lot more of our morbidity, and certainly the increasing mortality in the US comes from, a lot of these are C-sections. We have our accreta risks, the VTE risk that goes along with that. So it is a safe alternative, but you really want to set yourself up for success. So obviously making sure that you 24-hour coverage of anesthesia, obstetricians, and ability to do an emergency section if needed, but really giving the patient choice that this is an option for them.
What about outpatient ripening?
So I love this topic, but I really can't get some good buy-in personally. So if anyone has any ideas, I think the biggest thing with this is really implementation, but it has such a great idea behind it because the patient satisfaction is just so much higher. And the cost effectiveness is better too. So in the meta-analysis and in the individual studies, there is pretty consistently a shorter time on the labor and delivery unit. As we all know, that's a very costly place to be. It's about 7 hours less when you look at these studies, which is great. Patients are home and they have the comfort of their own bathroom, their own bed, and it's not loud, which is great. Recommended that we use a Foley catheter, so prostaglandins are not recommended because, of course, there's the potential risk for hyperstimulation, the meconium risk, and you're obviously not monitoring the fetus. And like I said, they're the highest patient satisfaction values. The issue is that I think is how to get these patients scheduled and also a culture change. So people just aren't used to it. And so, I know even here you have to make sure that there's a bed available if they have to come in labor, and really haven't gotten that buy-in yet. And then there's also some concern like, well, patients don't want to go in, have a Foley catheter that have to be hanging out for the entire time that they're home. And so maybe in the future, as you said, that there's more clinical trials with laminaria, if that becomes a more viable option, maybe we can start considering that for outpatient ripening too. So these just things on the horizon. But I think as more people get induced, we have a higher morbidity in our population. And certainly as people are considering that 39-week induction, these are the best patients to consider for outpatient ripening, to get them out of your labor and delivery unit, have them mobilized, walking around, surrounded by their support system, and at home.
I think one point I want to stress, I was always worried about safety. What about if you send a patient on with a Foley? And again, the only Foley should be used in this case for outpatient ripening. Mm-hmm. And what about if she has an IFD? Or what about if, she comes in and, there are late T cells, like category 3 tracing or, whatever. And in that Pierce-Williams, Rebecca Pierce-Williams did a beautiful meta-analysis. And, half outpatient, half inpatient. So over 350 patients were randomized to outpatients. And it's not a huge number, 350, but it's not a small number either. No IUFD, no, no reassuring testing when they came back. And, like you showed, quicker times in L&D. I think then that we begin to have some good safety numbers. And I think both you and I are certainly for it.
So, even more so, we have just such a great deal of safety data around Foley in general. So Dr. Scissione and his colleagues had published their experience after their first trial, like what was the risk of having an adverse event while the Foley catheter was in place. And yes, these patients happened to be inpatient, but they were just reporting on the adverse outcomes. And it was like virtually none. They had, I think, one bleeding episode, which happened in the first kind of hour of Foley placement, which is why they kind of designed their trial around having, an hour or so of monitoring after Foley. But that was really reassuring. And then you have a subsequent meta-analysis by, I believe it's about 20,000 patients by Dr. Moles, shows, again, with Foley catheter, virtually no adverse outcomes. So you have all this data, and yes, it may be inpatient, in a lot of respects, but it's a very safe method to use. So I think if your patient does want that is certainly something to consider. And it just goes along with a culture change. So for our patients that do qualify for outpatient, and again, they're rare, but we are doing it. We do send them home with instructions. So I do strongly recommend that if you do start practicing this, have a guideline in place that your nurses and midwives and obstetricians can follow, giving good patient instructions and education. So this is what we developed, and this is courtesy of Dr. Thompson here at Bay State Medical Center. And this is what we hand out to our patient. And on the first page of this pamphlet has a list of all the emergency numbers for all the different groups, when to call. And so far, for patients who do choose this, they've had a lot of, satisfaction with this, which is great.
Well, about 4 minutes left. Let's go to the last couple of points we want to make.
All right. So lastly, so when to call a failed induction. So this is based on more observational trials, observational data, obviously, but really should be diagnosed after 18 to 24 hours of oxytocin, ideally after you've already ruptured their membranes, and at the very least amount of having oxytocin for 15 hours. And that comes from the Safe Labor Consortium data showing that after 15 hours, really the risk of maternal and neonatal complications increases. And just a good side note for people just to be aware of, on average, the length of labor is about 16 to 17 hours for nulliparous women and 9 to 10 hours for multiparous women, just to give you an idea of how your patients should be progressing. And obviously that number is going to be a little bit different as you factor in things like BMI, which is known to significantly lengthen the amount of time you're in latent labor if you're being induced.
And again, the last bullet is really important. We mentioned it briefly before. This is the length of labor after induction.
Yes.
And you usually using two agents like you recommend, foliamide or foliovoxitosin. And those numbers are not that big. If you do it right, you can actually have, get to 6 centimeters plus, don't have a failed induction, and have labors that are not that long. What about some indications briefly and timing?
Yeah, so this is available in our article, so you can see it a little bit better there. So these indications are mostly to balance either maternal risk of worsening medical disorders or the fetal risk of stillbirth. So I think it's important that you know that it's not taking into account the chance of having a successful induction per se. So chronic hypertensions, for example, are being delivered between 38 to 39 week. That can be altered if they're uncontrolled. Preeclampsia with severe features at 34 weeks or afterwards by diagnosis. Diabetics can be delivered anywhere between 34 and 38 weeks if they're poorly controlled. And again, I recommend, especially if you have MFM input, to seek their input and hopefully try to get them to better controlled if possible. And then we have a couple more indications here. The growth restrictions, again, can vary depending on the degree of abnormality in their umbilical artery Doppler. And these are available in ACOG as well, and some of the committee opinions and practice bulletins in more detail. So I encourage interested people to obviously go to that. And it's something I regularly refer to as well. So like I said, this is more in line with balancing maternal risks of morbidity and fetal injury and stillbirth. The only thing that really has to do with a little bit of both, but also reducing the risk of C-section is really that 39-week delivery for everybody. So I don't know if you want to just touch on that briefly, because I think we have 2 minutes and it is quite a topic.
Yeah, let me go over this slide quickly. So even before the ARRIVE trials, there were over 150 randomized studies, over 30,000 patients randomized to things like you discussed, preeclampsia, they have preeclampsia, diabetes, FGR, whatever, as an indication, a proven indication for induction, and they did better with induction. That's why we induced them, with that beautiful graph that our colleagues did. So even before the ARRIVE trial, we knew that induction compared to expectant management, which is really the comparison. You have somebody at 39 weeks or 37 weeks with severe preeclampsia or whatever, and you decide to induce. If you don't induce, they're going to have more C-section, more stillbirths, more NICU admission. And we knew this 8 years ago, 10 years ago, many randomized studies. So it's really been a culture change. I encourage people to look at this, when they consider the ARRIVE trials that came after and other newer trials, The evidence has been there for a long, long time. I was taught that induction was a bad thing. That's what I was taught, 30 years ago. And I think it's completely changed, 180 degrees opposite. Induction for complex patient, it's a great thing. Saves really maternal life and morbidity and neonatal life or morbidity. And then if to worry about C-section, which is the big elephant in the room when you talk about induction, it's incontroversial, for 39-week induction or other inductions. That's I strongly think that there are many benefits and really no risk I can see. So why don't we put some bullet points at the end here and conclude?
Sure. So, what the following that we strongly recommend, obviously, following the guidelines ACOG puts out, and if you're following, you're in the UK, the NICE guidelines for various maternal and fetal conditions, you really should be talking to your patients about offering them that induction at 39 weeks. Patient choice has a lot to do with this as well, but they should know what the evidence is and make their own decision. You're going to be doing cervical ripening with hopefully a combination of Foley catheter and misoprostol or oxytocin, whatever is best for your particular patient. And then for your patients with PROM, proceeding promptly with an oxytocin induction, hopefully within 6 to 12 hours. So the following have some weak recommendations, not based on the strongest data. So membrane stripping at the start of induction, again, it might not even be helpful for multiparous women. Early amniotomy, and I actually think that this can probably start to move over to our stronger recommendations based on the number of trials and the recent trial coming out of Christiana. Stopping oxytocin in the active phase, again, possibility, but not a really strong recommendation. And then considering outpatient Foley induction for those women who are, low risk with a Foley catheter, and the indications for a failed induction are really 18 to 24 hours of oxytocin after hopefully membrane rupture.
Corina, you've been fantastic. I had a lot of fun, like usual. I hope, as usual, it's usually over 1,000 people that watch us live and watch us later on Facebook, YouTube, and Twitter. I look forward to another session next week. We'll talk about a huge controversy, vaginal progesterone versus 17 HPC for patients with prior preterm birth. A meta-analysis just came out this week in Age of MFM. And so we'll see you next week, May 25th, on Facebook, Twitter, and YouTube again. Corina, thank you very much, and thanks everybody for listening.
Thank you.
Bye-bye.